All audio is through your computer speakers. Please submit any questions and comments via the chat box on the right-hand side of your screen. The question and answer portion of today's webinar will take place after our featured webinar, but please feel free to submit any questions or comments throughout the duration of the webinar in that chat box. And finally, this webinar is being recorded and will be distributed to all participants. It will also be logged onto the NACCHO's MAC network webpage for you to view. You may also view all of our old archived webinars there as well. So first, a few quick updates from NACCHO. Our next webinar for the MAC network will be in September, tentatively for September 25th. The topic will be cyanuric acid. More details to follow. I also wanted to make a quick announcement about NEHA's assessment of recreational water health. Visit neha.org/node/59129 to participate in their assessment to help better understand the health hazards presented by recreational waters. As I mentioned, you can view all of our archived webinars and MAC resources on NACCHO's Model Aquatic Health Code Network webpage. For any questions or to join the network, you can email macnet@naccho.org. And just a quick announcement, we do not have any official updates today from the CDC. However, they are on the line and they will be available and participating in the question and answer session to follow the main presentation. So are there any questions for NACCHO? And you can submit them in the chat box and we can answer them as we move along or following the presentation. And now we have a few updates from Doug Sackett, the Executive Director of the Council for the Model Aquatic Health Code. Doug, the floor is yours.
Thanks, Chelsea, and welcome everybody to this afternoon session. A couple updates on the MAC update process. As I mentioned before, we have about 180 change requests that were submitted, and they're all available for review. You can see the website for our CMAC website where you can view all the change requests. The Technical Review Committee is continuing the review process. It's underway. They've only got a couple meetings left, and hopefully to wrap up the reviews so they can be issuing their recommendations to membership. Again, the meeting schedule is available on our CMAC website under the burgundy button, top right, find 2017 info on. You have to check that regularly because we do update the schedule and what CRs are being discussed on which call. I expect to be posting the new schedule, the revised schedule with the CRs before Friday's call. And again, a reminder, CMAC members can join the conference call, but as listen only. Okay. One of the changes, the member comment period for influencing the Technical Review Committee reviews and recommendations remains open until the TRCs complete their reviews. Originally, that was scheduled to close on May 31st as far as accepting submitted comments, but we realized the value and the fact that the TRC schedule is ongoing, that throughout the process as members are listening in and they have comments to submit to the TRCs for consideration, we reopen that period. Only members can submit comments, and you need to open a specific change request and then select the button at the bottom to add a comment. And it's important to get them in as soon as possible because they are considered during the Technical Review Committee deliberations. The last item of note is that the MAC Vote on the Code Conference registration is open. It did open April 3rd. We were getting a number of registrations, but I'd like to encourage the CMAC public health members to take part in the process, the MAC update process, through their input on comments and all that. But we're encouraging you to be on site at the conference because it provides the opportunity for networking with your fellow CMAC public health members. And there are caucus discussions where the different sectors get together. We have organized group caucus sessions where you can discuss as a group some of the deliberations and your comments on some of the change requests. There's also a discussion of all change requests, member comments, and technical review committee recommendations, and there'll be a CMAQ annual update. So my contact information is listed here, and it's also on our website. And here's, again, the websites for the CDC, for the MAHC, and CMAQ's website information. And with that, I'll turn it back to Chelsea.
Thanks for those updates, Doug. So now I'd like to introduce you to our speaker for the main presentation. So Pieter Sheehan is the Director of the Division of Environmental Health with the Fairfax County Health Department in Fairfax, Virginia. Since 2012, he has overseen the regulatory and outreach activities, including body art, child care, drinking water, food safety, lodging, on-site sewage, public health nuisance, recreational aquatic, indoor air, and vector surveillance and control. Prior to Fairfax County, Mr. Sheehan was with St. Charles County Department of Community Health and the Environment and St. Louis County Department of Health, both in Missouri, Monterey County Department of Health in Salinas, California, and Maricopa County Department of Environmental Services in Phoenix, Arizona. Thanks for being with us on the call today, Pieter, and the floor is yours.
Thank you very much, Chelsea. I hope everyone can hear me. Well, good. So let's get started right away on this. What we're going to be talking about today is a couple of direct themed ideas and some indirect themes. We're really talking about the MAHC, but a lot of us at the local level have yet to adopt the model aquatic health code. So what today's really about is what can you do today? What can I do now to get this this process going? And we're going to demonstrate to you aspects of the MAHC that can be used right away and can enhance your program even with an older pool code as you move forward to getting to the point of adoption of the MAHC. So we have a few learning objectives today. I'll start off a little bit about who we are. We'll talk a little bit about systems thinking, and then data and how data is very important in the modern public health world to help us with our decision making. We'll talk about the actual risk factor study that we did in the Commonwealth, and then also we'll end up with some conclusions. So I'm joined on the call this morning with another staff member from Fairfax, Mr. David Lawrence, who may help me as we go through this, bring some points up on the subject. Fairfax County is in the Commonwealth of Virginia. We belong and we're part of a larger agency, the Virginia Department of Health, which is the main office of Environmental Health Services is in Richmond, Virginia. Fairfax County sits in the northern part of the Commonwealth. It's a large jurisdiction, approximately has 1.2 million residents. It's best known for being the headquarters of the CIA in Langley, Virginia, as well as George Washington's family home, Mount Vernon. Because of the large population within Fairfax, there's a lot of risks associated with water recreational facilities. We have a very diverse population in Fairfax, and so our community outreach has to be a little bit more vigorous in terms of how we outreach to folks who need to approach water recreational facilities differently than other folks, depending on their language barriers, etc. The risk of injury and illness at any public water recreational facilities usually include the big ones: drowning, chemical injuries, and of course exposure to pathogens, which can lead to disease. Swimming is the most popular recreational sport in the nation. Fairfax County has over 1,200 pool vessels. Originally, the pool program was positioned along the same program elements that you see in consumer protection, so your restaurants and hotels, et cetera. A couple years ago, we decided to move the pool program out of that section and move it into a section that we thought was more technically inclined to look at these types of units. So it was moved to the on-site sewage and water section. This group has a higher level of understanding of pumps and pipes and a lot of the technical stuff in the pump rooms. And then, of course, due to the water stuff, they are well versed in water. So it was a good fit. And all the inspections of the 1,200 vessels in Fairfax are done by everyone. So it's the only regulatory program in the jurisdiction that everyone does inspections of. So it's the common program that we all do. 28% of the vessels are wading pools. And these, it's important to keep a note on this because these are classified as high-risk vessels by the MAHC. Again, the MAHC was published in 2014 to help bring standardization to these pool codes that exist across the nation. The current pool code in Fairfax County is one that's been around for a while. And so what we our goal is to bring our pool code up to standard. But it's been an imperative of mine to make sure that we start working towards that goal and do it in such a way that as the code is passed, we're almost already living the MAHC and its different aspects of what makes it a great code. And so an emphasis of mine has always been a risk-based approach to studying environmental health regulations. You know, a risk-based approach allows you to augment or make your enforcement and compliance program dynamic, and it helps continuously improve areas that may need to be improved. So if you look at all your units within any of your regulatory programs as static and the same, what happens over time is that the way you look at them may suffer in terms of the overall public health reasonings why we're out there. So basing your units within risk, studying the risk, keeping your eye on the risk, allows you then to get a better grip on what's going on. And so this presentation is really about what can I do today? I have I see adopting the MAHC in 6 months or a year, or I haven't been about adopting the MAHC. What can I do closer to adopting the MAHC by changing some administrative functions within my current program? So the question you'll start out with is where were we? You know, and Fairfax County was effectively doing inspections of our pools. We were doing pre-opening inspections across the board, which took a lot of time. These inspections were done prior to the operation of the pool before the season started. And then we transitioned into inspections during the season. There was really no kind of risk, looking at these vessels from a risk perspective at all. We met the mandates of how many pool inspections we were supposed to do, so there's no question that we weren't doing our job. But the inspection form was a simple, and it didn't really focus in on clear risk factors that could impact public health and safety. There was, a lack of uniform inspection process. You know, this is a big thing in local public health. It's hard for us sometimes to get our hands around it. and uniformity. And what I mean by that is that if you're in a large jurisdiction or a jurisdiction with 2 or 3 individuals, can you say 100% with 100% certainty that the inspections are being done adequately or the same from 2 different inspectors or from 2 different sides of the county? So this lack of inspection process or the standardization is key to what we do. And it's again, approaching your regulatory, the regulatory aspect from a standard code, and then also delving into what is it, why is it that we're doing inspections? You know, our engagement with the pool industry was limited to the application they filled out every year and the inspections we did. As I said earlier, Fairfax County is a very diverse jurisdiction. We have a lot of folks who speak English not as their first language, and so it's key that we understand how to get to these communities to help them understand pool safety. And then variances. There was really no guidance on variances. Variances were allowed through our pool code, but we didn't have guidance on how to grant them. The MAHC, with its introduction, now is our main guidance for how we approve or not approve variances. So where do we want to be? Where do we want to be? Well, you know, community-based public health is key. Trying to find the social determinants of health is key in public health. And what do I mean that? How do we find social determinants of health in environmental health? You know, you hear about social determinants of health in the clinical side of the house, but you don't really hear about it in environmental health. So social determinants of health, just as a reminder, that is when public health, we study things as access to health and healthy foods, ability to get to your doctor. Is there transportation from your house to your doctors? Your poverty level, your income level. These are what we call social determinants of health, and together they help us understand our community's public health backbone, for a lack of a better word. So in environmental health, is there any commonalities between social determinants of health on the clinical side and the environmental health side? I would argue absolutely yes. That if we were collecting data in the pool program from a risk-based perspective, we would be able to begin to understand which pools are giving us trouble, and then what types of folks are using those pools, which may allow us then to either increase our community outreach, which is a key component of good public health, and also invest our energies into those pools that may have community members that need more guidance on staying safe in the water. So where we want to be is a community-based program with improved health outcomes. And it's key to remember that standards is the way to do this. For those of you who know the food program, the retail food program standards is a guidance for the retail food program. You can start a standards program with the MAHC tomorrow, and it's a very well-written document based in science, and therefore a standards program can be designed relatively easy. And then we need to also remember, as part of this, is a community-based program. We need to understand that industry means more than pool management companies, hotel industry, architects, designers, etc. That it also includes, you know, a lot of other folks that touch either directly or indirectly our aquatic environments. And as local public health, I think that's where we are the most efficient at helping our state and federal partners understand what that is. So how are we getting there in Fairfax County, and how can we help maybe you get a little bit further too on this? Well, the goal, remember, of the MAHC and the goal of good public health is to reduce recreational water illness, injuries, and death across the board. You know, in the spring of 2016, we had an MPH Practium project that helped us with the activities that I'll show you a little bit later on our risk factor study, and get in more details there. But this slide's really meant to give you the overall picture. What are the risk factors in terms of water recreational facilities in your jurisdiction today? Could you list them out for me? How effective is your program at the surveillance of these risk factors? What do I mean by surveillance? Do I know what the risk factors are? And then is there a way for me to test over time what's going on with those risk factors? And then do we have a risk-based inspection program? Are we going to all pools equally, or are we going to those pools that show or have demonstrated the highest need or the highest risk? And then importantly, do we have a two-way communication in terms of risk with the community and industry? This is a very key component. This is why I'm a big supporter of MAHC, is that it is beginning to set the groundwork for two-way communication with the community and industry. And of course, as we know in public health, that's what we call our health promotion activities. You know, our data and decision making is becoming the new the words that everyone's using in public health. There's a lot of public health departments that are getting accredited now, and so data and how we as public health officials use that data is key. And so in a program like the water recreations or the aquatic program, what's nice about it and with the new MAHC is that you can start doing this today. You can think about it tomorrow, but you can start it today. What do I mean by that? Well, first of all, look at the MAHC. Look at it. It's a big document, but look at it in its parts, and keep in mind the definition of what it is, what the definition for conditions most directly associated with illness, injuries, and deaths. And so that would be risk factors. I have the MAHC reference on the screen here, but you can just Google MAHC and it'll come right up. So the key activity during this process is really comparing, well, first taking the MAHC and looking at it and spending some time with it, and then taking your local ordinance and seeing where there's commonality and where there are differences. The best way then, once this comparison is done, is then to take the information about your risk factors and think about how surveillance could be done. So you have, let's say, in your current code, 6 risk factors that you honestly see that are there, and let's say the CDC presents 20. The best thing to do then is to ask the question, how can I use these factors to do surveillance? The surveillance will then generate data, and that data then will help you argue or make the point of the case for something that you're seeing in the inspection format. The easiest thing to do to use this, or to use risk and to use data and through its decision making without adopting a new code. So remember, what I'm talking about today is what can I do today in preparation for adopting a new code to get the ball rolling. And an inspection report, the inspection form you use to inspect your pools, is a good place to start. Usually an inspection form can be changed pretty easily at the local level. And so there comes a point where you want to look at your inspection report and ask the questions, you know, what does my inspection report show? Compare it with the aquatic facility report to identify gaps in the tracking of risk factor compliance. And I'll show you an example of that in a second here. So then, after we've done this comparison, we've looked at the MAHC, we've looked at our code. We probably know our code, right? We use it every day. So it's really the MAHC that we have to start with. We looked at our inspection reports, compare it to the MAHC. Let's move now to really making this program that we have at the local level a risk-based inspection program. So one of the easiest things to do is to simply revise your inspection report to improve your risk factor surveillance. You've identified some. Maybe you wish you had more of the CDC that are in the MAHC. You'll get those when you adopt the MAHC. But at this point, what you can do is you can start putting the framework together so that when the MAHC is adopted, you're already collecting some of the data that will be very relevant in the future. So make sure your inspection reports clearly identify risk factors. Develop a set of marking instructions so that there's uniformity and consistency across the board with inspectors who are doing the inspections. Training, classroom and field, with not only the inspection staff, but with the pool operators also, making sure that everyone's getting, when the pool inspectors go out and do inspections, it's not about just hitting someone for a violation, but also educating the pool operators. And then continuous quality improvement. So this quality improvement is a program at the program level, not at the individual level, I would argue. And to change the approach that you do as you see risk factors being more cited in the field than you would like, think about what you could do in community outreach or education to pool operators to bring that risk factor down. Compliance and enforcement procedures, of course, is the end-all for the process of risk factor surveillance. So here's our process that I went through pretty quickly, and I hope not too fast earlier. The process. Assess the Model Aquatic Health Code. Get a copy of it, put it on your iPad, look at it every so often when you have some time. I know we're all busy, but look at it. Compare it with your pool code. See where there's commonalities with your pool code. Then focus on the risk factor provisions in the MAHC, and then try to find them in your own code. Then finally compare the inspection report that you currently use with the MAHC Aquatic Facility Report, and see if you could make changes with that report that then would allow a better surveillance program to be attempted in your jurisdiction. So you have not adopted the MAHC. You've not really done anything other than rethink how you look at swimming pools. We're going to the class data-driven model in which data is driving our decision-making. And all you've done is you've taken an inspection form and made it more explicit so that you're pulling out data points that will be relevant to this decision-making in the future. And of course, the future is adopting the MAHC. But the key point I want to make here is that there's a lot that can be done before you adopt the MAHC. That adopting the MAHC and then getting going may be a hard thing to lift. So this is another process that you may want to use. So I'm going to go really quick into our risk factor study that we did, which helped us get to this inspection form changes and everything else that we did. So I will try to breeze through these because I want to check my time here. Yeah, I'm doing pretty good, I think, on what we did. So this was the methods of our risk factor study. We looked at the risk factors to water recreational facilities as determined by the CDC and other jurisdictions or other U.S. counties. So we gathered the forms from the CDC. Remember, we're looking at the forms and how they're delineating these, and from about 10 other jurisdictions. We then crosswalked the Fairfax County Code with the inspection form and the inspection form to the Model Aquatic Health Code's recommendations. The second objectives were to analyze 4 sets of Fairfax County pool inspection data collected over 24 months to identify trends in noncompliance. So once we did the crosswalk and we identified the specific risk factors that we could pull out of our data, we then wanted to look, was there any trend in noncompliance? To do this, we had to clean up the Fairfax County inspection data. By that I mean it was not delineated specifically. Although the data was being collected, it would need to be delineated a little bit better. We had to categorize the inspection by facility type. Was it a swimming pool, spa, wade pool, water feature, etc.? So we knew this from looking at the file, but the inspection form didn't actually in and of itself tell us that. And then we needed to analyze the violation data for trends in the categories of numbers per inspection, facility setting, risk factor type, inspection category, etc. Then finally, we wanted to compile a report, summarize the results, compare with the national violation trends, and create recommendations that what we needed to do to change our design of our database, our pool code, which would be obviously adopting the MAHC, but really the inspection form and the inspection process. So although all this is gathered in one sentence, there's components of this that could be done earlier than others. Code changes take a while. So really quick for your, so that you know, the CDC's critical risk factors are in front of you. Pretty straightforward. We've seen most of these before. And I won't go through them at length. The risk factors in Fairfax County, once we went through and looked at the pool code and compared it to the crosswalk, we were only able to come up with this list of critical risk factors. And just to go back, you'll see there's quite a difference in some of these. And I would argue that some of these are actually in our code. They're just not delineated right. So the language is not there so that we can pull it out. So here's the crosswalk. So the inspection form, which David, the inspection form was put out, correct?
Yes, the inspection form. So what you're seeing here is our inspection form at the beginning of the risk factor study conducted by the MPH practicum student.
Okay, and we have released our inspection form to the audience?
Yes, that is available as one of the files. There's if they look for the front, the inspection form front.
Inspection form front. Okay, so this is basically the inspection form front, and what you're seeing here is the different items. Now, under each item, there's numerous code violations, right, that are possible. And then what they did was it was a crosswalk before anything between our item numbers and the critical risk factors that the CDC buckets, correct? David, I'm correct on that?
Yes, so the very left-hand column on that was the five categories on our inspection form: documentation, water quality, safety, equipment and construction, recirculation, other. And then we have 35 inspection items or numbers on our inspection form, and those corresponding descriptions. And what the table shows is how the CDC risk factor categories, which are general safety, illness, non-drowning, injuries, and drowning, correlate to our risk factor surveillance tool, our inspection form.
So when we went through this process, we found the following. So we found the following violations during this period from our inspection categories. And just to not lose you, you'll see to the left the blue, orange, gray, yellow, blue. Those are our inspection categories. And you'll see the breakup of our violations from those inspection categories. Now, the question you can ask is, what does this tell you? Is this telling you any risk? And that's the question you need to keep in your mind. So during the same period, and this is just additional information, during the same period we had the vessel closure rate at the following. Although we didn't keep the type of facilities, we were able to glean whether they were apartments and municipals by going through the file. So this is somewhat time consuming. Instead of putting it on the inspection form, we had to actually go back and look at what things were, which is foreshadowing something that we changed. And so we had 24 closures during this period. So moving forward, if you look at, and I want to say this is right here, yes. So if you look at this, this is just a chart version of what I'll show you in a second. This is showing the violations of our pools. A long line after our inspection form was crosswalked with the CDC's critical risk areas. And I don't like the chart as much as I like the graph versions of this. You can see now the violations that we were seeing, were highly weighted in the illness area of violations. So let me emphasize what has happened. We had data that was collected on inspection forms, that the inspection forms were not 100% useful to collect all the information in the field quickly. So then it took someone to not only take the inspection forms, but to go back and maybe, well, they had to do a crosswalk between the old code, or our code and the MAHC, delineate which violations were belonged in the CDC critical risk area. So once that work was done, and that's a one-time only kind of set of work, then you had to collect data a little differently, and we were able to get to a point of graphs that look like this. And to be honest with you, this graph is quite different than the violations by inspection category. You can see the, where you can get yourself in trouble. So the next question you're going to have to ask yourself is this: well, what were the illness violations? Were there commonalities between them, et cetera, et cetera, et cetera? And that's the next steps in usually a risk factor study. So what were our conclusions? Well, we needed to change our inspection form. Our inspection form was okay, but there needed to be some additional things put on it so that we could ferret out risk factor stuff easier. First, specifying the aquatic facility setting. That was a no-brainer. Specifying the disinfectant type. You think we did that? We did, but we didn't do the type of disinfectant. Separating the no lifeguard violation into two separate items, the credential versus proof of. So a lot of times we'll go out there, someone doesn't have the proof that they're lifeguard, and we only had one area to check on that. So that piece of data, we couldn't delineate whether it was just because they didn't have the credential or were they not lifeguards. Separate the presence of the CPO operator versus demonstration of knowledge. This is key. So just because you have a CPO license, can you also demonstrate knowledge of a certain set so that I know that you know what's going on out there? include actual numeric values measuring for both total and free disinfectant. We weren't doing that. Specify which violations led to immediate closure. Standardized inspector observation statements. This is key. In Fairfax County, all staff from the environmental health director all the way down does pool inspections, and so the standardization of the observation statements is key, especially when you're dealing with different levels of staff who sometimes don't feel they have to write down as much as others. Add additional MAHC categories to the inspection form. And then some other general recommendations outside the inspection form was prioritize data entry from the inspection items of greatest impact on public health. Is it key that we put everything in the database that is not really impactful to public health? And then test water quality at all wade pools during all inspections. We weren't doing that. And then increase the inspection frequency for wade pools, interactive water features, and water parks. So in a nutshell, you're interested in doing this risk factor study, identify, compare, directly associate, collecting the data, and analyze. What do I mean by that? Identify risk factors. Take your old code and the MAHC. Get the MAHC. I gave you the list of the CDC, so now all you have to do is do your local code, do that crosswalk, compare your two codes. That's the starting point. And then define the risk factors in your code that are directly associated with illness, injury, and death. That's a key part of this. Compare the inspection report, your inspection report, with that of the MAHC aquatic facility report. Then do analyze the current risk factor, the data that you're able to glean. And that is it in a nutshell. And that is, it sounds like it's a lot of work, and it is a lot of work, and if you did have the help of a MPH student, it helps a lot. But something like this can really send you going on moving this program to a point of it really being a sound and a program that you can actually generate to making some important decisions. In, out, NA, repeat, and corrected during inspection. Those are key changes that we did. An evolution to the MAHC inspection form. This has introduced MAHC as part of our inspection process. So adding this in here is what really changed our inspection form closer into line with the MAHC. This has nothing to do with taking code language or code sections and adopting them. This is what this is doing is simply getting my system ready for the adoption of MAHC. Remember, and then also remember in the C in the red next to the item numbers. Those are the critical risk factors, conditions that are most directly associated with recreational water illness, injury, or death. These were based on a comparison of the MAHC critical element provisions with our local water ordinance, recreational facility ordinance. This is a progression to improving surveillance and targeting control of risk factors. When you initially do this, and I would argue even if you could snap your fingers and adopt the MAHC tomorrow, what we're talking about today is really something that should be done, because you're going to also have to educate staff on what the changes are going to be. So this process of changing the structure helps that to occur. So that's basically all I have with the risk factor study. I hope it made sense. So it's just a few plugs about where we are as local jurisdictions and MAHC. You know, there's not a lot of local jurisdictions that have adopted the Model Aquatic Health Code. When we're in the process of, you know, still constructing the way we're going about getting this adopted at the local level. But, you know, I'll say this as a local environmental health person my entire career, local is where it's going to be done at. And so I would, recommend that you really look at the Council for the Model Aquatic Health Code, get involved on this. Even if you're an on-site person or a food person or a vector guy, following this process at the early stages that we are now will really help you understand the administration of the environmental health programs at a level that will be useful to any of the elements within environmental health. So joining one of the work groups in the council is highly recommended. Work together. Look, the way we do this is we find another local jurisdiction that is thinking about this, spending a few moments talking to each other, and trying to figure out what can I do to make this work. And to remember that success starts today. It's not going to start tomorrow. It's not, you know, people are going to retire in a few years. It's not going to start then. It has to start today. Public health is a dynamic field that needs people who are forward-thinking and understand that our communities change all the time. And so start today. Think about it tomorrow, but start today. And so in Fairfax and in the Commonwealth, Virginia, and I know I can speak for the Office of Environmental Health Services in Richmond, that, you know, Fairfax will be here if you need some assistance. If you want to call us and just shoot the breeze and talk about, you know, how do I go about doing this? I've listed some names up here, everyone from environmental health supervisor to David and to Shannon, who are our senior environmental health specialists on the pool program, to myself. Give us a call, and we'll help you navigate through this whole process. And that is all I have. Hopefully I kept it in the time range.
You were right on time. Thank you, Peter, for that. Yeah, thank you, Peter, for that presentation. And thanks for folks for your patience as we dealt with a little bit of cutting in and out there, but I think we got the gist of it. And thank you again for that wonderful presentation. And now we move on to, we have about 10 minutes for questions and answers. So what we've been doing is kind of collecting the questions throughout that you've been submitting in the chat box. And then we'll present them to the speaker, and he will have an opportunity to respond, but also we do have those folks from CDC and CMAQ on the line who can chime in as appropriate. So the first question we had is, how often are the pools inspected in Fairfax County?
The pools are inspected minimally twice a year, but due to complaints and issues that we see in the inspections, they're usually inspected more than twice, but twice is the mandated minimum.
Thank you. The next question was, do any of the violations that you mentioned fit into multiple categories?
David, can you help me on that one?
We have tried to streamline our inspection report and our violation numbers, so it will only fit in one of the item numbers, but that you will find that there is some duplication, but it may only be based, you should be able to identify just one item number that's most specific to what you're observing as a violative condition.
Great, thank you. The next question is, at what point do you close a facility?
Well, I mean, that's, I would argue, close it for imminent public health reasoning. The reasoning is the usual reason, but there's the operator of a swimming pool needs to know when to close his pool or her pool. And so the use of, we're at the early stages of this, but active managerial control, the idea that folks will run a swimming pool, understand the code, understand when things are going awry, and then closing the pool on their own is where we need to be. That's good public health. The jurisdiction closing a swimming pool is usually done for, just egregious public health reasonings. There are a few that are not super egregious, but that are actually in our code, so we have no authority not to close them. But
and Peter, those reasons would match up with the Model Aquatic Health Code, imminent health hazards.
Okay. Yeah.
All right, thank you. So the next question we had was, with illness above 50% in all of the categories that you showed in the pie charts, what is being provided to operators in order to reduce those numbers?
Well, look, the illness violations were, what's interesting about that pie chart is that it's showing the same set of data that had been gathered, prior, and re-illustrated, I guess, for lack of a better word, re-illustrated out to show that the majority of these violations were violations, according to the CDC, that led to illness. So what we needed to do is focus in on those specific violations. Now, do all violations directly have a direct link to illness, the cause of illness? Probably not. If you find a piece of chicken in a store or in a restaurant that's not the temperature, that could lead to illness, but it doesn't necessarily mean it's going to lead to illness. What's key about the pie charts is not so much going down into the details, because remember, Fairfax County has not adopted the MAHC yet. What we've done is adopted the structure of how we're reporting out our data. And then moving to looking at those violations within the 50% range on what we can do to get the numbers down. And to do that, we use a combination of educating the pool operator companies, outreach to the people who run who manage the properties. We are also trying to get our community outreach to folks who actually use swimming pools up to a level that will help us at these violations, with these kind of violations. David, anything to add?
Well, the question is, what are we doing in response to that? And this is our reason for increasing our engagement with the industry. And also, I saw a question posed about what are we doing as far as demonstration of knowledge, evaluating demonstration of knowledge during our inspections. So we're incorporating health promotion activities like education outreach with industry as a bigger part of our inspection process, and trying to achieve active managerial control as a concept for pools.
Yep.
Excellent, thank you. So the next question we had was, does the pool operator have to hold a certification like a national or a state CPO or a certified pool operator?
Yeah, there is no, from my understanding, there's really no national standard. The one thing the MAHC has been really instrumental for us is in our local code, to have a certified pool operator class, you have to basically get permission from the department. And our code didn't really tell us about how to go about proving a certified pool operator course. The MAHC does an excellent job of delineating what parts need to be in the course. And so we've used that part of the MAHC to actually help support our own current code, which is really old, to get people's classes approved. Yeah, so yes, when you go out to the pool, there has to be a certified pool operator out on the deck or out in the pool area. And then the process of which courses do we accept, we that have now used the MAC as the way we go about approving those. And I think, David, that application went out also.
Chelsea, if it's working, I just tried to upload that document.
It's not working, or is it?
This is Chelsea. We do have 5 files that are available to download, and I'll just point everyone's attention to them. They're under the chat box, and you can click on the title of any of those files and download them to see what the folks are talking about. And these were also sent out ahead of time.
I just tried to upload the pool operator application that we have, but I'm not sure if it's working.
Okay, that one should be part of the files.
Okay. So that application is just what all that application is using the MAC to guide our current code's process of adopting. But there is no national, from what I understand, there's really no national standard. And whether it was in Missouri or in California or wherever, that was always an issue of local public health having to approve these courses. I'll be in Richmond in not too long in the future, and that's one of the things I'm going to bring up with the Office of Environmental Health Services with the Commonwealth, is maybe we could come to a better understanding of, in Virginia, how really we should be approving these courses.
All right, and we have 2 more questions I think we can fit in before the end of the hour. So the next question is, are lifeguards required at all pools, or is there a difference between public community pools and apartment/homeowner association communities?
I thought I'd get this question. Virginia, or in the Commonwealth, there is not a requirement for lifeguards at all swimming pools. However, within the Fairfax County, within Fairfax County, we require lifeguards at every swimming pool present. There's some political backlash on that. The motel lobby is not, super happy that lifeguards have to be present at all pools. It's been a historic requirement here in Fairfax County. But in the rest of the Commonwealth, outside I think one jurisdiction that's next to us, does not have that requirement. So again, nationwide, I think there's, and then coming from St. Louis and obviously from out west, there's no, from when I was out west, I never saw a lifeguard outside of a hotel, a larger hotel, or a municipal pool. But the use of lifeguards at all swimming pools, or the lack of them at all swimming pools, is a political decision. And in Fairfax, it's required at all swimming pools currently, although we have given some variances to swimming pools not to have them on a case-by-case basis.
Okay, great, thank you. And the last question before we wrap up is, why is there not a not observed category in your inspection form?
Thought there was.
Is there?
Peter, there's not a not observed column. It's not because we couldn't fit one. It's because we were finding that would not be a marking we would utilize based on how our header's set up, that we're collecting information on one vessel at a time. We're not going to a facility and trying to put all the vessel inspections on one report. We're actually doing one vessel at a time, and we really weren't. The NA was the best choice over having NA and NO.
I see. Yeah, that's right.
And so, unlike the food risk factor survey, where they use the data for NO to either support the in or the out of compliance, we didn't need that in this case with our study.
All right, great. Thank you for that clarification. And since we're just at 2:01, my clock says, I'd like to thank everyone for joining in for our webinar presentation today, and I'd like to thank our main presenter, Pieter Sheehan. And just as a reminder, These slides and the presentation itself will be archived on NACCHO's Model Aquatic Health Network website. Thank you again.
The chairperson has disconnected.